to the next steps, and one of which is around the ADC doublet story. And we saw at ESMO, Brad presented a really nice investigator-initiated phase 1 trial of enfortumab vedotin plus sacituzumab govitecan. Sacituzumab govitecan is a TROP2 ADC. It has SN38, a topoisomerase 1 inhibitor as a payload. And those two drugs seem to be active together with response rates of 70% and manageable toxicity. Shilpa, what was your take on that phase 1 trial, and what does it mean for us moving forwards?
I think it was a good study to show that it's doable with non-overlapping toxicities and showed responses in majority of patients, right? But the toxicity can be challenging even though they are not overlapping.
Yep.
And I think one needs to come up, it's good to see that these trials are doable and there's efficacy. I think just the dose optimization and how many cycles we need, and then followed by maintenance therapies.
Do you think we're going to be doing more doublet, triplet trials? Do you think is this study the start of a new group of trials, or do you think it's going to be really challenging?
I think if they move to the front line, you know, the bar that EV-302 has now raised, it will be really difficult to beat that unless we have a really promising ADC, which we can add to EV-Pembro to beat that. I think that is going to be the next step in your discussion, like you had outlined, you know, the 2 antibody drug conjugates and immunotherapy, and then go from there. I think we'll really need to be careful. We don't want to be like the kidney cancer world where, you know, we're throwing the kitchen sink at the patient at the risk of
We're going to be better than the kidney cancer. That's for sure. Petros, there was a study called THOR. THOR has 2 cohorts, and it tests erdafitinib, which is an FGFR inhibitor, in patients with FGFR alterations. And cohort 1, which we've seen before, to be fair, compared erdafitinib with chemotherapy in heavily pre-treated patients, and showed that erdafitinib was significantly better, both from progression-free overall survival and response rates, with about a 36% reduction in the risk of death, which was really attractive. But then at ESMO, we saw a more confusing trial, or more confusing results, in my opinion, where the erdafitinib in these FGFR altered patients was compared with pembrolizumab, and we showed there a hazard ratio for survival of 1.18. What happened in that trial, and why have we got these divergent results?
Tom, great point again. So one message for the audience is that we need to test with next-generation sequencing cancer tissue at the time of diagnosis of metastatic disease in order to inform our subsequent therapy steps and to see whether erdafitinib may be an option in patients who have FGFR2 or FGFR3 activating mutation or fusion. We did an adjuvant trial that is a separate story that did not fully accrue. But in the metastatic disease, we need to test cancer tissue for FGFR2 and 3 activating mutation and fusion. And it's important to look at the fine print on these genomic panels to make sure these genes and assays are included in the tests, because sometimes may be missed. With that background in mind, we have the THOR trial, 2 different cohorts, as Tom, you alluded to. Cohort 1, that was a very important question, erdafitinib in this selected patient population versus taxane in the US or vinflunine in Europe in patients with prior immunotherapy, and most of them had prior platinum-based chemotherapy. So this was a pretreated population of patients, erda versus taxane or vinflunine, and there was a clear overall survival benefit, hazard ratio 0.64, favoring erdafitinib in this selected patient population, which about 20% of patients in our practice have this mutation or fusion in FGFR2 or FGFR3. I think Dr. Loriot saw the data with a subset of patients, and more or less with different degrees of benefit, patients across different subsets, they had benefit with erdafitinib versus chemotherapy, taxane or vinflunine. Now, the second question, the second cohort of this trial was erdafitinib versus pembro in the second line in platinum refractory population. So patients had platinum, chemotherapy had progression, did not get available maintenance in that sense, and they had erda or pembro, again in the selected population with FGFR2 or 3 mutation or fusion. That trial showed an interesting result. There was no significant difference in overall survival or PFS with erda versus pembro in the selected population in the platinum refractory setting. Now, you may argue that the PFS slightly numerically favored erda, but there was no significant difference. Response rate almost double in favor of ERDA 40%, with ERDA 22% with Pembro. My practical take on it is, number one, Pembro is likely to move frontline based on the EV302 trial, so this data may be less applicable in the future, at least in the US and countries with access to Pembro EV. Having said that, I think it helps us select the sequence of therapy. If someone is in the dilemma between ERDA and Pembro after potential prior platinum-based chemotherapy or prior EV, and you're between ERDA and Pembro, if you need a response right away, visceral metastasis, liver mets, explosive symptomatic disease, hyper disease burden, I would go for ERDA. The advantage with Pembro is if you get a response, 22%, these responses can be durable. So the tail of the curve came and pretty much, you ended up with, high responses with ERDA, tail of the curve with Pembro, similar to what we saw with TKI and IO in kidney cancer, Tom. So no OS benefit at the end of the day between the two agents. A patient selection where you use ERDA versus Pembro in these patients.
Do you think the biomarker's fabulous?
I think it's a good step in the right direction, and like Petros said, we should test everybody. I think for the FGFR, yeah, it is fabulous because we have a drug for it.
Yes.
But for treatment selection, in general, for immunotherapy, we don't have any fabulous biomarkers.
I agree with that. Sia, at the same meeting, and actually at AUA, and going back to, going back, we discussed actually at ASCO GU together. We made a video, one of our disastrous videos, well, from our perspective, not from yours. You were fabulous. The story now is evolving. There is a story evolving around the THOR program. Yeah. There's THOR 200 and THOR 210. I think that has the potential to be transformative. Do you want to just talk a little bit about what's going on with that program in non-muscle invasive bladder cancer and some of the ongoing trials and how it could change things?
Absolutely, yeah. So let's talk about THOR 200 first, because that was the first agent that was sort of put into trial. So this is a completely novel delivery mechanism into the bladder. We're used to putting any kind of solution in the bladder. It's always the same thing, 1 hour, once a week for 6 weeks. No matter what we put in, that seems to be the recipe. And we've gotten good response. BCG response rates are great. So this is a novel delivery mechanism. This is what they call a pretzel that's placed inside the bladder with a catheter. It goes in sort of straight. It has a nitinol wire. Once it enters the bladder, it maintains a pretzel shape, and this thing is filled with little gemcitabine tablets that dissolve and elute the drug over a time period into the bladder. So what you think, well, gem doesn't really have that much activity in non-muscle invasive bladder cancer. The prior phase 2 and 3 trials have shown like 20% response rate in non-muscle invasive bladder cancer that are BCG refractory. However, when you think about it, the sustained response is really the key. And gemcitabine is a very active drug, as you all know, in bladder cancer. So initially, we had the phase 1 trial just to see. This was in 2016 with a company called Taurus that designed the pretzel, put it inside the bladder. We did it as a neoadjuvant sort of window of opportunity trial, and we put it in. We actually saw results. This was visible results with the pretzel, very, very well tolerated. So obviously, this has moved on to the various trials they now call the Sunrise trials, 1, 2, 3, 4, in the various states of bladder cancer. The most exciting one so far, and the one that's been presented numerous times at the various meetings, is the Sunrise 1 trial, which is the THOR 200, again, same pretzel, gemcitabine tablets, BCG unresponsive disease. And I presented the initial results at the AUA just in May, and at ESMO, they had the updated results with 30 patients having a 77% CR rate. That is more than anything we've ever seen in non-muscle invasive bladder cancer so far. There are other agents that are coming along with combination therapies that are similar, but this is really exciting for a device that is placed in the bladder, that is easily retrieved and very well tolerated. The AEs, if you look at it, grade 1, 2, stuff we're all used to with the urinary frequency, irritative voiding symptoms. So 77% CR at any time. There are 6 patients who are over now a year in treatment. They're tolerating it very well. They now get it quarterly. Initially, it's every 3 weeks, and now getting it quarterly. So I think no question this is going to have a place in the management of bladder cancer, non-muscle invasive bladder cancer, and it's going to be part of our armamentarium. It's easy to place, easy to learn, easy to remove, and the patients really like it. So that's one. We've been talking about ERDA, and you know, we've been following this very carefully, and like Petros said, we had the approved 302 trial with infigratinib, another selective FGFR3 class inhibitor. And so in non-muscle invasive bladder cancer, we have about 30% FGFR alterations, and in low-grade disease, it's actually 60 to 70% alterations. So it's natural to think, okay, somehow we got to get ERDA into the non-muscle invasive. Initially, we started out with the oral agent. I actually was given it myself. Learned about all the toxicities.
I'm impressed.
Yeah. Impressive skills by Dr. Daneshmand, of course.
But
not only
no, thank you. I'll hand it back over to you guys. So we saw responses. This is a cohort of THOR-2 trial, the cohort 3 with low-grade cancer. We discussed it at GU ASCO, oral erdafitinib for a non-muscle invasive bladder cancer. We actually saw responses. We saw these tumors go away. Amazing results. Very few patients, but amazing results, like within 6
There was that interesting part where you actually left the tumor behind and gave an oral tablet, and I thought that was really like very innovative. But it's not the easiest tablet. It's not. You know, it's not like enzalutamide.
Exactly.
It's like a proper drug.
Absolutely. And yeah, I got to learn that the hard way. So we're using 6 milligrams, which is a little bit less than the 8 or 9 milligrams that you use for metastatic disease, but nevertheless, we saw all the nail toxicity, the hyperphosphatemia, and the skin changes and things like that. But nevertheless, it was active in both low-grade and high-grade disease. Cohort 1 of THOR-2 trial was a high-grade disease. So it's natural for that to move into now an intravesical delivery system, and that's exactly what they did with the TAR-210 study. And now they have the erdafitinib tablets within the pretzel, and we're using it in again, multi-cohort trial. It's multiple cohorts in both high-grade disease as well as low-grade disease. Again, the preliminary results are super exciting, and some of it was presented.
I think it's like one of the best innovations in urology, like for a non-urologist.
And isn't it crazy when you look back and you say, well, you put something in and why can't you run around? And you know, it just seems like a logical next step. I think it's potentially transformative.
I think so too.
You think they can put pretty much anything in that pretzel? Like,
so
ADCs or?
I think so. I think in the future it's all about the sort of biochemistry of how you're going to get the drug and the urine to elude the drug within a certain time period and not have the toxicities. Fortunately, these drugs so far are not very toxic to the actual normal urothelium, and we actually see this. We're scoping these patients in 3-week intervals, 6-week intervals, and we don't see that irritation, inflammation that we are so used to seeing with BCG, with mitomycin and other intravesical,
And it's very interesting, you know, to your point, Tom and Sia and Shilpa, how much we're learning about drug delivery, right? Gemcitabine is the same drug we use for like decades.
Exactly.
And with the potentially optimal delivery, reaching the target, maybe sustainability of release, it's so much, maybe the pH in the environment, it's hard to tell, but the delivery of the drug may make a big difference. And to your point, Sia, the 77% response, clinical complete response rate was based on independent review committee. It was 80% based on investigator. It was a small sample size, to your point, with short follow-up, but very promising, potentially transformative. And I'm excited to see what other agents can be delivered intravesically. And the patients, to your point, Sia, are used to the intravesical delivery of agent, you know, even if it's solution or now a pretzel.
Right.